All right, hi everyone. I hope you're having a great day. So, if you are following the suggested schedule in the syllabus, then this week we have two topics. So, I've already done a video on disorders that are related to stress and trauma, and this video is going to talk about the first half of Chapter 7. So, Chapter 7 discusses mood disorders. So, we're going to wrap up the second section of the class with the first half of Chapter 7, which will talk about depression without mania. And then after we have exam 2, the first lecture that will go towards exam 3 will discuss the second half of chapter 7, which is going to be about bipolar disorder. So if you have any questions, let me know. Just remember that exam 2 is going to cover our lectures on assessment, diagnosis, and treatment, on anxiety disorders, on disorders of stress and trauma, and on the unipolar depression bit of chapter 7, which is what we're covering in this lecture video. So after you finish this video, you'll have all the information that you need for exam 2. Remember that there will be a review video and a practice exam for exam 2, just like we had for exam 1. Please let me know if you have any questions. I'm going to go ahead and jump into lecture.
Alright, so as I said during this lecture video, we're going to be talking specifically about unipolar depression. So chapter 7 in your book is about mood disorders. And today's lecture is going to focus on the depression without mania, and then after exam 2 we'll come back and we'll have a discussion of bipolar disorder, which would include depression and mania. So how common is unipolar depression? Unipolar being contrasted with a bipolar depression. Well, once again, our statistics are rough estimates at best, but around 9% of adults in the U.S. suffer from severe unipolar depression in any given year, with about 5% more suffering from milder forms. So we do know that depression is common. While the anxiety disorders may be the most common diagnoses given, depression is also fairly common. Around 19% of all adults, so almost 1 in 5, experience unipolar depression at some point in their lives. So we're going to be talking today about how when an individual has depression, there are several different ways that this can manifest itself. It can be different severities. It can be different combinations of symptoms. And so what we do know is that depression, while it is common, it may be a little bit hard to diagnose because there are so many different ways that depression can formulate, so many different ways that depression can manifest itself. So one thing that's interesting is that the prevalence rate for depression is similar across many different countries. This tells us something. So there are some disorders, eating disorders would be one example that comes to mind. Some disorders that are found much more commonly in certain cultures than in others. So eating disorders, as we'll talk about later in the semester, are one of those things that we see almost exclusively in Western cultures. And we'll talk about why that might be when we get to that lecture. But the fact that depression has very similar prevalence rates across different countries tells us that there's something here that is not culturally specific. Now, the way that depression manifests itself can look different from place to place. We'll cover that later. But the fact that it happens, and happens in a pretty similar amount across cultures, tells us that there's something, whether it be biological or some kind of cultural experience that is more universal, that seems to be contributing to depression rather than something that is specific to certain cultures. One thing we do see is that depression is more likely to be diagnosed in individuals living in poverty. As we've already talked about and will continue to see, this is true for several different types of disorders. And it may be one of those situations where an individual in poverty has additional risk factors because of all the different layers of stress that can come along with living in poverty. It may also have something to do with individuals in poverty not having access to health care, not being able to afford health care, that kind of thing. Now, what does depression look like? Now, as I said, we're talking specifically about unipolar depression today. So we're not going to be touching on mania during this lecture. There are 5 main areas if we were to take the symptoms of depression and try to organize them into areas of functioning. One thing to keep in mind, though, is that there's a pretty good bit of overlap between these categories. So, for example, emotional symptoms. So, this is the way that the person feels. This has something to do with experiencing distress. You'll see the criteria, or there'll be some examples of the criteria on the next slide. But emotional symptoms are required in order to give a diagnosis of depression. So, a person has to be experiencing either one or the other of these emotional symptoms. So, on the one hand, the first one would be having a depressed mood, which could basically be any kind of negative emotion. It lists here miserable, empty, humiliated. There are many other terms people might use when they're describing that emotional feeling, but basically someone who is sad. And or we also have to have someone experiencing little pleasure. Now, I don't know if this term is in this set of slides, if it's on one of the slides, but you should need to know it. Anhedonia. Anhedonia is the term for an individual who's experiencing a loss of pleasure. So this would be someone who maybe previously enjoyed certain hobbies or enjoyed spending time around certain people. And then once they start to experience those symptoms of depression, they stop enjoying those things that they used to enjoy. So in order to receive a diagnosis of depression, you have to have one or the other or both of the emotional symptoms. But there are other symptoms as well, and as I said, there's a pretty good bit of overlap here. Motivational symptoms, individuals who have been diagnosed with depression oftentimes have little motivation. So motivation is anything that energizes your behavior. A person who is lacking in motivation is someone who maybe doesn't want to get out of bed, doesn't want to go to work. If they do go to work, maybe they don't enjoy it and they don't put as much effort into their work as they used to. This could also be someone who is not motivated to have relationships with other people. So a lack of motivation to put up with other people can look like isolation. Now, it lists suicide here. It talks about between 6 and 15% of those with severe depression die by suicide. We are going to have a lecture specifically about suicide when we come back after exam 2, so part of the material for exam 3. So we'll talk more about this then. It's interesting that your book lists suicide under motivational symptoms, and of course, as I said, there's a pretty good bit of overlap, but it may feel as though an individual does not have the motivation to continue to live, and so then suicide seems like a viable option for that individual. One thing that would be important to know is that some of the highest risk times is when a person is coming out of a major depressive episode. So you would think that when a person is in the deepest, darkest part of a depression would be when that person would be at highest risk for death by suicide. And that is a time of risk, of course, but the time when risk is highest is actually right after a person experiences that kind of episode. What we see is that sometimes individuals who are severely depressed at the moment, maybe they don't feel like they have the motivation to even plan something like an attempt at suicide. And so what we see is that when a person starts feeling a little bit better, starts getting a little bit more energy back, then they might start to have the motivation to consider death by suicide, and also may feel like they're trying to prevent themselves from getting back into the place they just got out of. But we will talk extensively about suicide issues as part of our material for exam 3. Also, behavioral symptoms, so you may see changes in a person's behavior. You may see a person kind of going back to motivational symptoms, be less active, less productive. Maybe going back to that anhedonia, they don't engage in behaviors that they previously enjoyed. I'm not sure which one of these categories you would put this, but individuals often have a loss of sex drive, which could be a motivational symptom, could be a behavioral symptom, could be considered a physical symptom, but a person usually has less sexual desire during a period of depression. Cognitive symptoms have to do with your thoughts about yourself. We're going to talk later about different theories of depression, and we'll see that there is pretty significant research support for a cognitive theory of depression, that the way that people see themselves and see the world and think about the future impacts whether or not they're at risk for depression. And then also you may see physical symptoms. So this is more prevalent in some cultures than it is in others, but there are definitely some physical components that can be included. So for example, a person might have difficulty sleeping or maybe sleeping excessively. It could be headaches, dizzy spells, actual physical pain can be involved in an individual who has depression. So in order to receive a diagnosis of depression, you have to have some of these symptoms, but different individuals will have different symptoms with different severities. So just because two individuals have depression does not mean that they will resemble each other in the symptoms that they experience. Now, one thing to just remind you guys of, when we had our anxiety disorders lecture, I talked about the significant overlap between depression and generalized anxiety disorder. As I said then, it could be because the symptoms are very similar between the two, or it could be because one predisposes a person to develop the other. We're not sure exactly. Alright, so basically when you're diagnosing unipolar depression, there has to be two things. A person has to have a history of having at least one major depressive episode, and the person has to, at least at the point when you're diagnosing them, not had any symptoms of mania. Now, that sounds pretty straightforward. It can be a little bit complicated. A person may come in during a depressive episode, and so the thing they want to talk about would be the way they're feeling right now, the symptoms they're having right now. And so it might be easy for a client to not mention or bring up a history of mania. It might be easy for a psychologist to kind of focus in on the depression and not pay adequate attention to mania. It would be very important, though, to screen for whether a person has had an episode of mania or not, because an individual who has bipolar disorder, which would include mania, if we misdiagnose that and give them medication that is intended for individuals who have unipolar depression, it is possible we could make their situation worse. So we'll talk more specifically during the next lecture video about how to screen for mania. But a person has to have no history of mania, we'll leave it there for right now, and then had at least one major depressive episode. So what you're seeing during a major depressive episode, it has a 2-week period here. It could be longer than 2 weeks, but typically we're seeing at least 2 weeks, during which time a person displays at least one of those emotional symptoms we talked about. So depressed mood and or anhedonia, which is that loss of enjoyment or interest in activities they used to enjoy. In addition to that, there are some other symptoms listed here. So it talks about weight change or appetite change. You may see someone's appetite go up or down, so then weight could go up or down. It talks about insomnia or hypersomnia, so you could have a person who has difficulty sleeping, or a person who is sleeping excessively and maybe still feeling tired, so fatigue, lethargy. Fatigue is a difficult symptom because oftentimes it's very nonspecific. When you go to a doctor and you tell the doctor you're tired, there are hundreds of potential reasons for that, and some of those reasons might be more biological and then some might be more psychological, and of course you could have both going on. Agitation or decrease in motor activity. So agitated motor activity might feel like that person who's very restless, has a difficult time sitting still. On the other hand, you may have a person who just doesn't feel like moving or getting up or doing anything at all. Now, also it talks about feelings of worthlessness or excessive guilt, so that could be emotional symptoms as well as could be considered cognitive symptoms because of the kinds of thoughts people might be having related to that. Reduction in concentration, so sometimes I have seen this happen where a client comes in thinking that they have ADHD, when really what's going on is they have depression or anxiety, and that's making it difficult for them to pay attention. And then also it lists here focus on death, suicide plan, suicide attempt. One thing to note is that it says you need to have 3 or 4 of these symptoms. Now, you need 5 symptoms total. So if you have both of these, then you would only need 3 of these. If you only had one of the emotional symptoms, you would need 4 of these. But you don't have to have all of these. Not everyone who is diagnosed with depression has had a plan or an attempt at suicide. So just something to keep in mind. All right, so once we have determined that mania is not an issue, so we're dealing with unipolar depression, there are basically two things to think about. This could be an individual who has major depressive disorder. Major depressive disorder is typically considered a more severe form of depression, but not necessarily a long-lasting type. Now, what we see is that sometimes people have recurrent episodes where someone has major depressive episodes kind of interspersed with periods of normal mood. So they feel normal for a while and then they can have kind of a relapse into another major depressive episode. But usually a person who has major depressive disorder has more severe episodes for a shorter period of time. On the other hand, you may see individuals who have dysthymic disorder. Dysthymia or dysthymic disorder refers to an individual who has symptoms of depression for long periods of time, but those symptoms are not as severe as you typically see in a person who has major depressive disorder. So these symptoms are mild but chronic. So lasting for usually at least 2 years. This is something that may be resistant to treatment, kind of difficult to treat here, but less disabling. So maybe this is a person who's still able to function, still able to have relationships. They're just struggling with some of these symptoms. Now, is it possible to have dysthymic disorder and major depressive disorder? Yes. An individual who has what we could call double depression would have dysthymia most of the time, interspersed with periods maybe of major depressive episodes. So that would be called double depression, the person who has both those shorter but more severe episodes interspersed with the longer but more, mild forms of the disorder. So yes, you can have both of them at the same time. What causes unipolar depression? We don't know for sure. What we do know is that there are some cases of depression that seem to be more exogenous or reactive, which means that they seem to be happening more in response to life events. So you may have seen this, you've heard of this. An individual has maybe a loss, a death of a family member. Maybe a person has a particularly difficult health situation, a person has financial concerns, whatever, something in the environment then leads the person to start developing symptoms of depression. On the other hand, we can have an endogenous depression. Now, when we say endogenous depression, we're basically saying we have an individual who is experiencing symptoms of depression but does not seem to have environmental causes, or maybe any environmental causes that are there are not very severe. So in that situation, we would be asking ourselves, where did this depression come from? There doesn't seem to be anything in the environment. I haven't had a loss or major stressor. And so in that situation, we might say, well, it's more endogenous or maybe more internal. So we'll talk more about that in a second. But referring to the exogenous or reactive environmental depression, it says people with depression do tend to experience a greater number of stressful life events during the month just before the onset of their symptoms. Now, think back to our diathesis stress model. It may be that a person has a predisposition, whether that be biological or social, psychological, whatever, towards depression. And then these stressful events happen and they can trigger these symptoms or kind of set these symptoms in motion. What we will also see, though, is that an individual, once they start having symptoms of depression, the symptoms of depression can produce more stress. So symptoms of depression can impact your relationships, can impact your work performance, can impact your physical health, which can then produce stressful situations as well. So stress can lead to depression. Depression can also lead to stress, so we can have a vicious cycle here. Now, if we're talking about that endogenous form or a biological viewpoint, a medical viewpoint of what causes unipolar depression, if depression were to be caused by biological factors, things like neurotransmitters or anatomy of the brain, then we would expect to find that it would run in families. And this is the case. We see that as many as 20% of relatives of those with depression are themselves depressed. So if an individual has depression, we would expect that there's about 20% of their relatives that also have depression. This is substantially higher than the 10% of the general population you would expect. So basically, having a family member who has depression increases your risk for having depression. Now, this makes sense on a genetic level if you share genetics with your family members. So if your parents have depression, you're at an increased risk for depression, perhaps because you received a genetic predisposition from your parents towards developing those symptoms. But of course, it's hard to do this research because oftentimes you spend a lot of time around the people that you share your genetics with. So it's possible that if your parents have depression and you have depression, it might not be because of genetics. It might be because you're modeling some of their behaviors or some of their coping patterns as well. And that's where adoption studies come in, but we'll talk about adoption studies in just a second. One thing we see about twin studies is that there is a strong genetic component, and that genetic component is stronger for identical twins than it is for fraternal twins. So this is where we need to take just a second to discuss the difference for any of you who might not know. So an identical pair of twins, a monozygotic, that's what the MZ stands for, monozygotic twins. This happens when, at the time of conception, one egg, one sperm, fertilized and then splits into two. And so identical twins would share almost all of their DNA. So when we're doing research on nature-nurture issues, twin studies tell us a lot because identical twins share almost exactly the same DNA. On the other hand, fraternal twins, these are dizygotic twins. The DZ is dizygotic. This happens when, at the time of conception, we have two eggs, we have two sperm, and so the results, the siblings, would be in the womb at the same time and probably born at the same time, but would not be any more alike genetically than any other sibling pair. So the different sperm, different eggs, they would share about 50% of their genetics just like any other pair of full biological siblings would. So what we see is that identical twins have concordance rates of 46%. So if one identical twin has depression, then the other identical twin has a 46% chance of developing depression. This is to be compared with that 10% that we saw in the general population. And when it comes to fraternal twins, if one fraternal twin has depression, then the other fraternal twin has a 20% chance, which is still roughly the same as any other, family member. We talked about having an increased risk if you're a family member. Now, fraternal twins do share the same amount of DNA as any other sibling pair. So fraternal twins are no more genetically alike than a set of brothers or sisters or a brother and a sister that are born 4 years apart. The difference is, though, they might have some shared environmental issues. So because they're born at the same time, they might have some things like maybe more bonding because they spend more time with each other and they're at the same age, so they may be a little bit more like the best friend situation. But genetically speaking, they're not any more alike than any other sibling pair. Now, twin studies tell us a lot about genetics. Adoption studies can also tell us some. Now, one thing to say about adoption studies is that this kind of research, while it is very interesting, often has small sample sizes because it's just not possible to get large sample sizes here. So that's one thing to keep in mind. But adoption studies happen when we have individuals who are placed for adoption. They're adopted by individuals who are not biologically related to them. And then we ask ourselves the question, whatever outcome we're interested in, will you be more like your adopted parents or more like your biological parents that you never met? So if your environment was more important, then we would expect people to look more like the people they spent time around, which would be their adopted family members. If your genetics and your nature are more important, we would expect you to look more like your biological family, even if you never met them. Well, what we do see is that specifically with severe depression, individuals are more likely to favor or have similar symptoms to their biological relatives than they are with their adoptive relatives. So this is strong evidence for a genetic component. Now, we know there's a genetic component at least to a certain degree. what kind of result are we having because of genetics? Well, what we may see is that an individual may have developed a neurotransmitter issue based on genetics. So we talked about neurotransmitters, about how they're released from the terminal junctions or the terminal buttons, the end of one neuron. They cross the synapse, that little gap, and they bind to specialized receptors on the dendrites of the next neuron, and that's how neuronal messages are passed. Serotonin and norepinephrine are two examples of neurotransmitters that seem to be implicated in depression. Serotonin in particular is one that we've had a lot of research on and that a lot of medications are aimed at. So, during the 1950s, when we were having our heyday for developing psychotropic medications, we found that medications for blood pressure were causing depression. So we were taking individuals who had high blood pressure but did not have symptoms of depression. We were giving them this medication that was intended to help treat their blood pressure, and we were accidentally producing symptoms of depression. What we found was that these medications to try to treat blood pressure issues lowered norepinephrine and serotonin. So that then gave us the idea that perhaps an individual who has depression may have depression because they don't have enough serotonin and norepinephrine. So then we started creating medications specifically to try to increase the effects of serotonin or norepinephrine, and we found that those are often effective in treating depression. So we kind of accidentally stumbled upon this, as we often do when we're creating new medications. But what we found is that depression seems to be related to serotonin and norepinephrine. Now, one thing that complicates this is that there may be other neurotransmitters at work. So there are some medications out there. I believe Wellbutrin is an example of one. There are some medications that treat depression, but that are not specifically for serotonin and norepinephrine. I believe Wellbutrin works on dopamine. So there may be other neurotransmitters that may be involved. Another thing that's interesting is that sometimes when a person's taking these medications, the serotonin increases in their brain before the symptoms get better. Now, you would expect that if this lack of serotonin was the problem, as soon as the serotonin increased, the symptoms would go away. But it may be that it takes a few weeks after the serotonin has kind of replenished in order for a person to start feeling better, and we don't exactly know why that is. But they do seem to be helpful. Another potential theory here is that depression could be related to your hormones. What we see is that people who have depression also tend to have abnormal levels of cortisol. Now, cortisol is a hormone that's released during stressful periods. So we talked about cortisol a little bit when we were talking about disorders of stress and trauma. So an individual might be under a lot of stress, and then excessive cortisol is released, and that cortisol may be causing some of the symptoms of depression. Of course, it's also possible that a person who's depressed then experiences stress that then causes the increase in cortisol. So all we can really say is there's a correlation between cortisol and depression. Now, what we've also found is that there seems to be a relationship between depression and melatonin. So many of you probably have heard of melatonin. You know a little bit about melatonin. Some of you may be taking melatonin. Melatonin is a natural hormone that helps people sleep. So your brain, your body needs melatonin to sleep, and it's released when it's dark, which is why it's easier to sleep at night. Now, there are some of us, myself included, that can sleep just about any time, anywhere. I'm pretty sure that's not entirely normal. Maybe the narcolepsy that runs deep in my family. But for the majority of people, it's hard to sleep during the day. Why is it hard to sleep during the day? Because the light suppresses melatonin. It tells your body now is not the time to sleep, you need to be awake. And then this is part of the reason why sleep hygiene can be helpful for a person having sleep issues. It's recommended that you turn off screens at least, I would say, 30 minutes plus before bed. Having your phone while you're laying in bed trying to go to sleep, looking at your phone, looking at your laptop, looking at the TV is not good, because the light coming off of those devices can suppress melatonin. So melatonin is something that is a natural part of our sleep-wake cycle. But when an individual has depression, they often have abnormal melatonin. Now, a person may have excessive melatonin and may be sleepy and have a hard time waking up and have kind of a lack of energy. Or a person may not have enough melatonin and may have difficulty going to sleep. So sometimes depression includes excessive levels of sleep or kind of a lack of sleep. I find it interesting here that melatonin has been called the Dracula hormone. I don't know much about Dracula, but pretty sure Dracula was a vampire, perhaps. I think the idea is that when a vampire is in sunlight, it kills them, or they shimmer, one or the other. But anyway, no, I'm pretty sure the idea is that the sunlight kills vampires, sunlight kills melatonin. I think that's where that term came from. But the idea is that a person, maybe if you could regulate their melatonin levels, that can help maybe decrease their symptoms of depression. On the other hand, we don't have just a biological view. Now, if you have a biological view, you're probably going to want to treat with medications, probably specifically medications that work on serotonin, SSRIs, and others like that. But there are other views of depression. A behaviorist view, so the behavioral viewpoint is that reinforcement and punishment, you've been trained to do certain behaviors that have not worked out well for you, and so then the treatment would be to try to replace those with more functional behaviors. So specifically with depression, the idea is that a person becomes depressed because they're not receiving enough reinforcement in their life. The balance between reinforcement and punishment has been thrown off. So maybe you feel like your social relationships are always punishing. People are always hurting you. Maybe you feel like your job is punishing. Your job is always negative. Maybe you feel like school is punishing for you. Whatever it is in your life, you feel like you have a lot of punishers, and at the same time, you don't have a lot of reinforcers. You don't have a lot of positive things that you enjoy going on. And so you can see how that could potentially trigger an episode of depression. And then once a person goes into an episode of depression, then this is likely to get worse because of those symptoms we talked about earlier. A person doesn't want to get out of bed. A person doesn't want to go to work. A person doesn't want to engage in behaviors they previously enjoyed, maybe doesn't want to be around people. And so the symptoms that led to you having depression can then, or the situation, not having enough reinforcers that led to you having depression, can get worse because of the symptoms of depression that put extra barriers between you and those reinforcements, especially the social rewards. So we see individuals may not want to be around other people, and we know that there are different personalities. We'll talk about personalities later and about how some people are more introverted and some people are more extroverted, and so there are some people who maybe feel like having that social interaction is more important to them than others. But even for the most introverted person in the world, you still need a certain level of social interaction in order to have a healthy psychological life. So when we're looking at this from a behavioral viewpoint, we do have a pretty good bit of research on this, and we see that this does happen, that individuals who have depression often are caught in this negative spiral. Because of a lack of reinforcers, they start having symptoms that make it even harder for them to get reinforcers. And so then the treatment for this would be to try to increase those reinforcers. It's called behavioral activation. The idea that even if you don't feel like it, we need to get you to do those behaviors that lead to reinforcement and stop doing those behaviors that lead to punishment. So there would really be two kinds of things you'd want to increase. You'd want to increase your client doing the things that feel good, and you want to increase the things that make them feel good about themselves. Like, for example, going out with your friends feels good, maybe. Cleaning your entire house doesn't feel good, but you feel good afterwards because you feel like you've accomplished something. So helping your client engage in behaviors, they may not feel like it, they may not want to do it, so you have to find ways to motivate them to do it, maybe bring in family members that can help them, and have a plan of activities for them to do that work for them. Now, behavioral activation sounds very simple, but it's actually a very effective treatment without the side effects that come along with medications. And it could, of course, be combined with a medication. Some of the difficulties with the behavioral view, though, it says the research has relied heavily on self-reports of depressed subjects. Now, this is true for all the different views of depression. So bearing that in mind, how do you know what's going on with your client? You ask your client. So self-report's going to be huge for any of your perspectives. But think about this. If a person is already depressed and you start asking them questions about things in their life that they enjoy, they're probably going to say, oh, well, I don't enjoy anything. I don't do those things that I enjoy anymore. And that could make it sound like that was the cause. But that may not be the cause. It may be a symptom. So an individual who's saying, I don't have anything reinforcing in my life, maybe they're depressed because they don't have anything reinforcing in their lives. Or maybe because of the way they think or because of their neurotransmitters, they already have a predisposition towards depression, and once they start having those symptoms, they cut themselves off from the reinforcers. So we don't necessarily have cause and effect here, but we do have a pretty strong correlation, and we do have some success with behavioral activation treatments. All right. Carrying on with our different perspectives, some individuals have a cognitive viewpoint, so they would say that your attitude and your way of thinking is what's causing your symptoms. Now, the cognitive viewpoint is applicable to many different diagnoses, but it's especially strong when it comes to depression. Research really supports a cognitive view of depression here, at least somewhat. There may be other things going on as well. There may be neurotransmitters, there may be behavioral issues, but cognitive issues are almost always there when a person has depression. Now, when we're looking at this, there are several different cognitive issues that can come up. First of all, a person may have maladaptive attitudes. Basically, your attitude is just your perspective on something. You could have a good attitude or bad attitude, a positive or a negative attitude about anything. You have attitudes about people. You have attitudes about certain types of food, certain types of music, certain TV shows. You have attitudes about everything. Now, you develop these attitudes in part because of your own personality, your own temperament, but also because of the attitudes that you spend, of the people you spend time around. So if you spend a lot of time around people who have negative attitudes, you may find you start having a negative attitude. Well, what we see is that individuals who have depression often have self-defeating attitudes that maybe have been going on for quite some time. So although the symptoms may not manifest themselves until later in life, we can see some of them starting in childhood. And yes, it is possible for children to be depressed. We'll talk about that during our lecture on childhood and adolescence. But these attitudes can start very early. Now, some of these self-defeating attitudes could be this kind of hopeless, helpless, worthless, feeling bad about yourself that then prevents you from doing anything. If you feel like you're a person who's not worthy, then you're not likely to try to engage in relationships with other people. If you feel like you're a person who's not competent, then you may not try to do anything new because you're certain that you will fail. So then, upsetting situations later can bring these negative childhood attitudes back up and can even make them worse. So it's one of those things where your attitudes might give you a predisposition, and then a stressful event might trigger those symptoms. Also, in addition to your attitudes, related to that, your thoughts, the literal content of your thoughts. When we start asking people, what kinds of thoughts do you have about yourself? What goes through your mind on a daily basis? We might have a person self-monitor, write down the thoughts that you have about the future. We see that people who are depressed tend to make some errors in their thinking. Just a couple of these to list. Now, one thing I want to say here is that what we're saying when we say these people who are depressed make errors, we're saying they're thinking differently than people who are not depressed. Now, briefly, I talked about how it's hard sometimes to label something as normal or abnormal. Maybe this is just the way that person thinks. So basically what we're saying here is that for people who are not depressed, the way you think is right, and people who are depressed, the way you think is wrong. That could be an accurate way of describing the situation, or it could not be. So this may sound a little bit arrogant as a clinician telling your client you're making errors in your thinking. Some clients might respond better to that than others. But what we do see patterns, maybe patterns would be a little bit of an easier, better way to describe that. Patterns of thinking. People who are depressed may make arbitrary inferences. In other words, they may jump to conclusions with very little evidence. So This person didn't answer their phone, therefore they must hate me and they're trying to avoid me. Okay, this person said no when I asked them out, so no one is ever going to love me. It's kind of that generalization from one situation to other situations, making conclusions that are not really warranted based on the facts. And then also, and especially, minimizing the positive and magnifying the negative. So a person who is depressed might start having these thought processes where they don't pay attention to the positive. They find a way to turn everything to a negative. Now, this kind of thinking could happen before the depression and trigger the depression, or it could happen after the depression as a result of the depression, but either way, it's going to make those depressive symptoms worse. Now, they also tend to experience automatic thoughts, which is a little bit like the obsessions you see in OCD. So they seem to have this steady train of thoughts that they might feel like they don't have much control over. They're always thinking negatively, and they have a hard time stopping themselves from doing that, feeling inadequate, feeling hopeless, feeling helpless, feeling like the future is not worth living. Now, one area of cognition related to depression that has received a lot of research is called learned helplessness. This research was actually done originally in dogs. The way they did this research, they would bring in dogs and they would put them into two different groups. There was one group that went through this little experiment where they were receiving electric shocks. I understand hearing about dogs getting electric shocks is not necessarily pleasant to think about, but it was interesting research that tells us a lot about humans as well. They were bringing the dogs, and in this one scenario, there was a way for the dog to avoid the electric shock. Maybe it was something a button to press, or something to, a switch to flip, or maybe a certain place to stand. If you stood on this part of the cage, you didn't get a shock. But the first group had a way to avoid the shocks. The second group did not have a way to avoid the shocks. It didn't matter where you stood or what button you pushed or what switch you tried to flip. It didn't stop anything. Now then, after doing that for a little while, they would take those dogs and put them both into situations where they could stop the shocks. The dogs who had been able to stop the shocks from the beginning would continue to look for a way to to stop the shocks, and they would find that way, even if it was different from the way they were originally trained to stop the shocks. But on the other hand, the dogs that had been shocked out of their control, there was nothing they could do. Even when you put them in a situation where they were capable of stopping the shocks, they didn't do it. They would just sit down, lay down, and take the shocks. Well, this tells us something potentially about an experience in humans with depression. The theory is that at some point in your life, maybe when you were a child, maybe when you were an adult, you felt like you lost control. You felt like life was shocking you, and there was nowhere you could stand and no button you could press, if you understand my analogy here. It felt like there was nothing you could do to stop it. And then because of that situation, you learned to feel helpless, to feel like regardless, there was nothing you could do. So that even later in life, when you were in a situation where you could stop the punishment and could gain a reward, you didn't want to do it because of this learned helplessness. So what we would have to try to do would be to take individuals who have learned this and through enough experience and patience and practice and reinforcement, try to teach them that they can be in control over their reinforcements and punishments again. Now, a lot of this research has focused on attributions, and attributions are basically your understanding of the cause of something. So, without realizing it, we're doing this scientific endeavor all the time. Whenever a behavior happens, we look for a cause, whether that be a behavior we did or behavior someone else did. So, if your best friend is angry, slamming doors, and you're trying to figure out, okay, my friend is angry. Why is my friend angry? You make an attribution. An attribution is the label you put to the cause you think is leading to this behavior. You might be right, you might be wrong, but you have a theory of an attribution. When you find yourself feeling angry, you'll also try to have an attribution. Why am I feeling angry? Where does this come from? Now, you might accurately identify where your anger is coming from, or you might get it wrong and blame it on the wrong thing, but either way, you form an attribution. Now, what we see is that people who are depressed tend to have a particular pattern of attributions. they tend to make attributions that are very, very negative. Now, these negative attributions could lead to depression, or they could be a result of depression, or both. Let me give you some examples here. A person who is depressed, who has had a difficult experience, might make an internal attribution that is global and stable. An internal attribution means it happened because of me. Global means it's going to be like this in every situation, and stable is it will never change. So a person who's depressed has a difficult experience, and they tell themselves, it's my fault. I mess up everything I do, and I will always mess up everything I do. Now, you can see why a person who has that kind of thinking would feel worse afterwards. Like maybe a relationship ended. Maybe somebody broke up with you. And you think, this breakup was entirely my fault. I mess up every relationship of every kind that I have ever been in, and it will never get better. Now, that person, if they're not already depressed, they're going to feel pretty depressed after that. So, on the other hand, as a clinician, we might try to get them to think differently. We might try to get them to think, well, the other person in the relationship also contributed to the problems. It's not just me. Just because this one relationship failed doesn't mean all my relationships will fail. I am capable of changing, and I can make changes for the better so that my future will be better. You can try to change the way they think. Now, a person who goes through a breakup and says to themselves, I made some mistakes, but the other person made some mistakes too. I'll try to identify what went wrong so I can fix it in the future, and my future relationships will be better because of this. That person is probably not going to feel depressed, or at the very least they won't feel very upset because they have hope for the future. So your attributions are huge, but in addition to your attributions, we also have to think about your surroundings, your environment. So a sociocultural theorist would say depression comes from the social context in which you find yourself. Now, we're going to talk a little bit about a family perspective, which would have to do more with the people immediately around you, as well as cultural issues. So maybe the culture at large, the influence of the media, government, or other aspects of your culture at large that impact your experience. So if we're talking specifically about family, social perspective, about a relationship between you and the people you spend time with every day or on a regular basis, this would suggest that people who are depressed might start behaving in certain ways that harm their relationships. And then once you harm your relationships, you're likely to become more depressed. So think about this. If your relationship with a spouse is not great, you have conflict, you don't have good communication, that could start to make you feel depressed. Once you start to feel depressed, you're probably going to stop trying in the relationship because you feel like you can't be successful. You'll probably stop feeling hopeful about the future. You'll probably stop thinking good things about yourself and maybe stop thinking good things about your spouse. Once you have those symptoms in place, that will even further deteriorate your relationship. And the more your relationship breaks down, the more depressed you become. So according to this perspective then, one of the best things we can do is take people who are depressed and build up the relationships between them and the people around them. So maybe we have family therapy, maybe we have marriage counseling, bring in a spouse, a sibling, a best friend, somebody close to you to be with you as you go through therapy to try to improve the social support, improve the quality of that relationship, and maybe decrease symptoms that way. Now, there does seem to be some research support for this finding, and a lot of the research on depression and relationships has focused on marriage. So, individuals who are separated or divorced display 3 times the depression rate of married or widowed persons. Now, think about that for a second. You would think that a person who is widowed would be more depressed. And probably for a short period of time after the death of their spouse, they are. But overall, a person who loses a spouse to death actually rebounds better on average, not everyone, but on average, rebounds, bounces back, and is happier than a person who is separated or divorced. And then they also experience symptoms. People who are separated or divorced experience symptoms that are double the rate of people who have never been married. So if then we could take an individual who has depression, who is having relationship problems, and try to help resolve relationship problems, even if that's not the cause of the depression, it can still help lessen the symptoms because that person has some social support. So there is a strong correlation between marital conflict and sadness. Okay, so if we're trying to focus on the sadness and we're trying to fix what's going on with the individual without fixing the relationship, we might be missing a very important component of that person's life. So the whole idea behind a sociocultural view is not to think of the person in isolation. We're not just looking at you and your experience and your symptoms. We're looking at you inside of your social context. And anything that makes your social context better also helps make you better as well. So people who are isolated, people who don't have intimacy, which intimacy does not mean sex. Intimacy means a psychological connection with another person. You can have intimacy with an individual as maybe a best friend or maybe a sibling or other family member. It doesn't have to be a romantic relationship, but individuals who are isolated and don't have intimacy are at an increased risk for depression. All right. Now, a multicultural perspective would kind of look at kind of bigger issues. We're going to talk specifically about gender and culture as part of this. So first of all, the relationship between gender and depression. I've already told you guys that we typically see women having higher levels of internalizing disorders. Internalizing disorders being things that you experience more internally, emotional things like anxiety and depression. Whereas we're going to see males are more likely to be diagnosed with externalizing disorders, things like substance use, aggression, that kind of thing. Now, women cross-culturally, so not just in our culture, but across different cultures, are twice as likely as men to be diagnosed with unipolar depression. Women also appear to have these symptoms from a younger age, to have more frequent and longer lasting bouts, and to respond less successfully to treatment. So women tend to have depression more, and if you take a woman who's depressed and a man who's depressed, the research suggests the woman will probably have some more symptoms, some more severe symptoms, and may have less success when it comes to treatment. Why is this? Well, first question would be, is this true? Well, that's a dangerous question. The research says this is the case. So what's the problem with our research? Well, there's a theory, the artifact theory, that women and men are actually not different when it comes to depression. I know, I just told you they were, but hang with me for a second here. Maybe the case is that women are more likely to seek treatment for depression. Therefore, they're more likely to be diagnosed with depression. Maybe truly there's not that much difference, but when men and women experience psychological distress, perhaps they respond to it differently. Perhaps women in general tend to experience psychological stress and turn inward, which is the depression and anxiety. Maybe men experience psychological stress and maybe they're feeling the same thing. Maybe the men are depressed, maybe the men are anxious, but because it's not as culturally accepted for men to be depressed, they tend to lash out and maybe seek substances or behave aggressively, and that's what they end up getting diagnosed with. So maybe the underlying problem is not that different between men and women, but because of the way our culture has a stigma, in particular against men experiencing depression, maybe that's part of the reason why our research suggests that this is not happening. Maybe our research isn't catching it. That's one theory. Another theory is it's possible that women truly do experience depression more than men, that it's not just an artifact of our research, but that it's genuinely true. And if that's the case, why would women experience depression more than men? Well, a couple of possible reasons. We talked about hormones. Women tend to have much more fluctuation in their hormones than men do. So men will go through a period of puberty, right? And then towards the end of a man's life, as he gets older, yes, his fertility declines a little bit, but that's nothing compared to what women go through. So when women hit puberty, And from that time on until they hit menopause, they're going to have a cycle that's going to fluctuate. So their hormones are different at different levels during different parts of the month, during different parts of their cycle. And then, of course, if a woman gets pregnant, there's a lot of hormonal things going on during pregnancy. And then in addition to puberty, women also have to go through menopause, where hormones change drastically once again. So perhaps this hormonal fluctuation makes women more vulnerable to depression. It's also possible that women experience more stress than men. Now, one thing to note is that because depression is happening in similar prevalence rates across cultures, for this to be true, we would have to be saying that women experience more stress in the majority of cultures, not just in our culture because of the numbers we see. But it is possible that women tend to experience more stress. Women are more likely to be the victims of trauma or crime. Women are more likely to experience things like workplace discrimination. Women are a little more likely to experience things like, in addition to maybe working, also having more family responsibilities, because women often take on more of an active role with children, house upkeep, taking care of elder family members. So women are more likely to be taking care of their own aging parents, as well as perhaps helping more with their spouse's aging parents as well. So yes, it's potentially possible that women just have more stress, which creates an increased risk. Also, when we're talking about a multicultural perspective here, it is possible that depression is impacted by the culture that you're in. Now, we already said that depression is less impacted by culture than some disorders, because we tend to find depression just about everywhere. It's a worldwide phenomenon. And there are certain symptoms that seem to be constant. So depression in one culture will probably resemble depression in another culture. But one thing to note is that the exact presentation can vary. So, for example, some cultures, I believe, if I'm remembering correctly, more like collectivist cultures, cultures that are focused less on the individual, more on the group, they tend to experience depression more as physical symptoms. So the person might have more pain, might have more sleep issues, might have more fatigue, nausea, or more what we would typically think of as medical symptoms. Versus in our culture, depression does not have as many physical symptoms, maybe tends to have a little bit more emotional symptoms. So although depression does seem to happen at very similar rates across different cultures, there are some unique differences in the way people experience depression between cultures. And so maybe there are some aspects of depression that are different between different cultures. All right, so that is the end of today's lecture. You do need to be thinking about Exam 2. Look for the review video to help you prepare for Exam 2. Let me know if you have any questions there. Exam 2 will only include the depression part of Chapter 7. After Exam 2, we will come back and talk about the other part of Chapter 7, talking about mania. And then during that next video, we will also talk about issues related to suicide as well. So let me know if you have any questions or if you need anything. Otherwise, I will talk to you guys during the next lecture video.